All right. Good morning. Good morning, ladies and gentlemen. This is session number 23. We're going to talk about a case, a pedunculated colon polyp, occluding the lumen. And we wanted to, as we are doing this, I should share with you that we started experimenting, sharing information on Zoom. And we felt that we should involve fellows in the panel discussion for two reasons. One is to help them learn how to be a panelist. And number two is to help them also think through. And when you are put on the spot, you actually learn a lot better. So today we have one second-year fellow from UCSF, San Francisco, Dr. Niem Hao, and one of our second-year fellows from UT, Houston, Dr. Zubair Khan. In addition to that, we have a regular panel that is Selvi, Roy, Sylvia, and Sriram. What I would like to ask is keep yourself muted, except for the panelists when they talk. And we want to give the first opportunity to both Niem and Zubair to talk about it, and then the panelists will talk in explaining what we're doing. And at the outset, I would like to acknowledge my mentor, John Stoline, for his support, Mr. Charles Butt and HEB for the grant, Angela Deal, a medical illustrator. And I want to thank Lara Romero, our chief endoscopy technician at MD Anderson. She helped me this week to produce a video on how to use the loop. We actually shot it last week. And then to my institution, the University of Texas, MD Anderson Cancer Center. So in addition to that, Roy has actually been very passionate about education. And he reached out to Dr. Carl Wayman. And I don't know how many of you know about Dr. Wayman. I just wanted to take a few minutes. He's a professor at Stanford University, a Nobel laureate. He received his Nobel Prize in 2001. Recently, he received a huge grant for education that is called the Edan Prize. Dr. Edan has actually established this foundation to help education. And this is a $4 million grant that Dr. Carl Weinman received. And he is instrumental in helping us rethink and change the way sciences are taught in undergraduate and graduate schools. So last week, Roy arranged a Zoom session with Carl and his postdoctoral fellow. And we have learned a few things about how to do Zoom classes and maybe how to develop mastery learning for endoscopy. So I just wanted to pay my respects to Carl for sharing his wisdom. So we know that in the past we talked about, when you see a pedunculated polyp, you go through the same steps, and you want to evaluate the polyp, you want to assess the risk of bleeding from that polyp, how do you resect it, and then if you're worried about cancer, make sure that you put a tattoo, and how do you retrieve and then look at the pathology and make further additions. So these are the principles that we always follow whenever we see a polyp. And this is a story. This is a middle-aged man who underwent screening colonoscopy, and a large polyp, occluding the lumen and the sigmoid colon, was found. And The endoscopist felt it was too big for a safe and complete resection, and he was referred to surgery. But before that, as an alternative, they wanted to see whether endoscopic resection could be accomplished. So that's the story. So here is a video. We reached up to the sigmoid colon, and we used an endoscope. This is a few years ago. And as you can see here, this is a large polyp in the sigmoid colon, and it was occluding the lumen here, and you have a pretty thick stalk. So one of the goals is I want people to get used to the Paris classification. What is the Paris classification? Is it a 1P or pedunculated polyp, or 1SP, that is subpedunculated polyp, 1S, that is sessile, and LSD is laterally spreading granular tumor. All right. So Zubair, what do you think?
I think it's 1P, the pedunculated polyp.
Okay, that's good. And so we've gone through this, and for the sake of anybody joining for the first time, pedunculated polyp, semi-pedunculated polyp, 1SP. And if you look at this polyp, it got a stalk and a head. It got a stalk and a head. That is a 1P or pedunculated. And then the other ones are sessile. And if the height is less than the width, it is non-pedunculated or flat. And then in that, it could be superficially elevated, flat, or depressed. And if it is more than 10 millimeters, it is laterally spreading tumor. And if it is granular, it is laterally spreading tumor of the granular type. If it is completely smooth, like a bald head, it is non-granular type, laterally spreading tumor of the non-granular type. Just bear with me for those who have heard this, just repetition is good to help others. So this is 1P or 1 pedunculated polyp. All right. So the next step is we talked about when you have a pedunculated polyp, you look at the head and ask a question. Is this a malignant polyp? Does this have malignant features? All right. Maybe I'll ask Niyam to share with us.
Yeah, Dr. Raju. I think the way the polyp is appearing, is quite large with that large stalk. I think the with the camera angle, I'll get to better. I like to get better positioning using narrowband imaging to kind of see the more closer defined detail with near focus.
Mm-hmm.
But then just looking at this one, the video kind of being played, it seems like there's definitely areas where it's maybe appearing depressed or kind of worn out, which I think Dr. Tikno always taught me. Those are the fine features of when it's concerned for cancer.
Okay.
So right now, I think based on just kind of what the video I have, I would say it does have some malignant features.
Right. So it looks like all this area onto the left looks benign, and onto the right, you see that there is a little bit of a fold, right? And I wish I had actually, when I was editing this polyp, I cut off quite a bit. This was a few years ago. And that area makes you think it is malignant. That's probably not unreasonable to think, given the groove that you have here, right here. And we would be much better if we actually went down closer, used narrowband imaging, and then used near focus. And unfortunately, this video was taken with the previous generation of endoscopes that did not have those functions. At least we didn't have the narrowband focus. And actually this polyp, for the sake of the observers, this turned out to be a benign polyp, but actually it's very important to go through the steps, go back, check with narrowband imaging, and check with near focus to see if there are cancer features. And I like the way you shared like a worn out appearance, that's what it is important, whether the head has a worn out, like a tire worn out feeling that makes you think it is cancer or not. Okay, so for the sake of people, others to appreciate this, here is a polyp. Actually, this was a polyp that Roy shared last week. And as you can see, it's got a worn out appearance that makes you think it is cancer. And I believe this came back as cancer. So that is very important. When you look at a head, you want to ask yourself, is there cancer or not? The next step is when you look at the stalk, you want to check how thick is the stalk, right? And Niyam, how do you measure the stalk thickness? One, visual impression. Do you use a roller? Do you use a snare? Or do you use an injection catheter? Take a photo with the injection catheter and then say, okay, catheter is about 2 millimeters. And then if you take it in the same plane, then you can measure the stalk by comparing with the catheter measurement.
Yeah. That's a good question. I think that I was taught by, it's really depending on attending base. For me, I think the visual impression, it's the most straightforward and easy since you're right there. Mm-hmm. We know that the diameter of the endoscopy or adult gastroscope, that's 1. And comparative to the stalk, to the polyp size, that can be helpful. But with some attendings I work with, we also try using biopsy forceps, given that we know the width of that. We can leave the biopsy forceps out and kind of estimate then. Another attending I had, we use a snare, and the snare is kind of you wrap it over the polyp, and you sort of it's very cumbersome, but I think that you try to open it up and close the snare, not to cut the stalk, but just to kind of have a tight fit. And we'll look at the tech end of the snare to actually measure the width itself. Mm-hmm. But I would say when I spoke with Dr. Satik, mostly visual impression.
Okay. All right. And majority of the people think is probably visual impression. And that's probably what most people do. But I think it's a good idea when we think about a visual impression. It's a good idea to take the lesion on its own, and then another photograph with the lesion and an instrument in the field, in the same plane, so that you could use instrument diameter to estimate the size of a particular lesion. So you need to get into the habit of taking that photograph of the lesion along with the instrument in the same field.
I have a quick comment.
Yeah.
Yeah, so although we all use visual impression is something that develops over a period of time. So in our minds, we are assessing with over a period of time of experience that we gained that this is how the size is. So since this forum is for different levels of experienced people, I think if I was a trainee, I would follow what Dr. Raju is saying in terms of developing that visual impression as to what do I mean by what I'm thinking is what is right. So that I think when Dr. Satikna says it's visual impression, it is that impression that gained over the years of his experience. So it will not be the same for someone who may be starting or started a few years. So that is the reason why to develop this comparison with another instrument.
Yeah, thank you, Sriram. Thank you. All right. So this is what Nayam is talking about. I think when he says about looking at the snare, you have the handle here. Normally, when you pull the snare back, the snare is inside the sheet. You open the snare, and gently pull the slider back, and then see that the snare tip is close to the tip of the sheet of the snare. And then you come to the handle and mark it. And this is what actually, when I was training, I trained at the University of Iowa with a gentleman called Bob Summers. Bob certainly shared this idea. I said, okay, make sure you measure so that you do it right. So we used to have a marker to mark it on the slider, and then open the snare, close the snare, and then measure the distance from the marker to the back of the handle. That's what is the thickness of this stock. So that's one way to do it. I think it's probably the most accurate way to measure the thickness of the stock. And the more important is, if you try to do this, you will avoid problems when you try to snare a lesion around a bend and it's a blind move. And if you catch a fold, you will save yourself from this trouble of cutting through a fold by looking at what you estimate is the distance and what it is here. And if it is too much, then you know that you may have to loosen the snare and reclose the snare. So this certainly does help when you are around a fold or around a bend and you're going through a difficult polypectomy. So, all right. So Zubair, what do you think? We got a thick stock, and how many vessels do you expect in the stock?
I would say maybe one large vessel.
Okay. Thank God you didn't come to the class for the last 3 times. So that otherwise it would have been a slam dunk for you, but it's very interesting, I used to think okay, big, it's like a tree trunk, one big vein inside, but the answer is actually multiple vessels based on literature that was done. Actually, this is a study. There's a study back in 2006 in GIE. It's a good study for all of you to read. And this study shows that that as the polyp base, the stock size increases, the number of vessels in the stock increase. So this is an important concept to keep in mind as you're cutting the polyp. You have to think that you have to coagulate every single vessel so that you don't end up with a big bleeding, especially when you have a thick stock where you have not only multiple vessels, but also large caliber vessels. So something to keep in mind. And this is a good study that is worth studying. This is in GIE 2006, page number 1004. So, all right. So this is, I want both Zubair and Niyam to think loud. How are you going to cut this polyp? So why don't I let Niyam go first? What will you tell your assistant to have everything ready, and how are you going to cut this polyp?
Yes, I think that the schematic of evaluation, the second part, prevention bleeding, I think that with a large polyp, given a multiple vessel, my biggest concern would be bleeding post polypectomy. So what is my method of kind of the safest approach? So I think that given that it's a large stock with a large polyp, I would ask my tech to, one, get the endoloop out. And I think here at the VA here with Dr. Stigno, we kind of train our staff and the techs ahead of time. So making sure that the tech that we're working with is comfortable using endoloop, and that'd be the first step. The other thing is getting the Irby out, because given that it's going to be most likely hot cautery after the loop is applied, and then making sure that if we are concerned for bleeding vessels and the end loop is not secured, then we will have at least some hot forceps or some clips available. But then again, the endoloop, if it's applied correctly, should have hemostasis and tamponade all the vessels. So then the first approach would be trying to get the good position, making sure the scope is straight, and making sure that we assess the behind the polyp, and then wrapping the loop around it, and then securing the loop. Trying to secure the loop more close to the base of the stalk, and then using looks like most likely a large snare, so snare master, to wrap around the polyp, and then setting the electric surgery to part most likely endocut. And then once we get that, then we'll evaluate the vessels if we need to treat locally with, again, heat or a clip.
Okay. So what I'm hearing, Niam, you've done very well. I think you've thought through the principles of management of a large pedunculated polyp. What I'm hearing is you go up and then come down. As you come down, you put the loop close to the base, and then you use electrosurgery to cut the polyp and be ready if you need to do additional things to control bleeding. Right? Is that a good summary of what you plan to do?
Yes, Dr. Raji.
Okay, that's good. I think that's fantastic. Okay, Zubair, what would you do? Would you follow what Niam said, and because I think it's a good plan, or do you think of something else? Because there are so many different ways to cook a meal, right? So
I think I will do the same. I will go with, I agree with the plan. So we will do the endo loop, and then with the hot snare, we'll do the, with the endocut Q, do the polypectomy and have some clips ready. I will clip the stalk, even if it's not like bleeding now, then because of the the use of RB or endocut Q, the vessel may be coagulated and it may not bleed immediately, but just to prevent the post polypectomy bleeding. And depends on, I think also it depends, like if we are doing the polypectomy like near the base end of the stalk, the base will be more, so it will need some clips and to prevent the post polypectomy bleeding.
okay, so you both agree. I think it's a good game plan. So let me ask Selvi, what would you do, Selvi?
Well, Raju, I'm really impressed by what our young fellows have said. I think it's a very good plan. I like the fact that Niam said he wanted to make sure that the endoscopy technician that he had in the room was comfortable with using the poly loop or endo loop. I think that's very important that you specifically ask the technician that they're comfortable, because if they're, or the nurse, whoever it is that's actually assisting you that day, because you can't assume that they're comfortable. Sometimes people will not necessarily tell you what their level of comfort is with it. And this is, I think we had talked about this last week, and I thought, this is not really a very common situation that we have, where we have such large pedunculated polyps that we come across. So it would be very natural for the people who assist us not to be as familiar with using certain instruments like the polyloop. That's one comment, and I agree with what both of the fellows said, and I'm impressed with their approach and their ability to communicate that clearly with all of us today.
Okay. Sylvia.
Yes, I would echo Selvi's point. Very good plan from both fellows. It's just impressive how well they summarized the steps. Thanks a lot.
No, thank you. Sriram.
Well, now you're forcing my hand to to differ from some of it for this sake of discussion.
It's not about differing. When we have a case, right, it's good to look at, okay, based on different experiences as we go through, to say, okay, this is one option. Maybe there are other options, whatever options, you could lay out all the options and say what you choose, right? That's good. That's good for people to understand. So.
No, in principle, I agree with your philosophy of trying to do things the same way every time, all the time so that there is nothing goes wrong when we do it next time. And having said that, I think it is also important to keep in mind the different levels of training of the physician as well as the assistants. And polyloop being a big deal for technicians, and because we don't use it often, not because we don't teach them. And if I knew this polyp was there and this is the only purpose for which the procedure I'm doing, then I would go through what you said last session, go through use of polyloop with my assistant before the procedure and then go ahead for the case. Whereas if I encounter this polyp during my routine colonoscopy, then I'm basing on whoever is there with me and have not had a chance to review. So I would say I would inject some amount of epinephrine in the head of the polyp with the hope that it would shrink. Also inject epinephrine into the stalk and then try to do the polypectomy. If I don't trust my assistant at this time for being able to apply the endoloop, I will just, because this stalk is not very thick, it is big, but it is not very thick. So I think I can do the polypectomy and then take care of the stalk after I did the polypectomy. And when I do snare it, initially I apply some coagulation current before I cut it, and with the hope that it would initiate the coagulation of the vessels so that I don't encounter too much bleeding for me to take care of the stalk and apply clips at the stalk.
Okay, that's good. Roy?
I think this is an issue that Raju and I and many others are trying to solve at this point, which is to say that we almost like gave up and say like, we cannot teach them, we cannot teach ourselves, we cannot teach the fellows. So we are just going to give up and then just do something that's not ideal. And we do these techniques that makes it a little bit more complex. We inject here, inject there, and all that. But what I wanted to say is that the purpose of what Raju had said in the beginning of this talk, and what we've been trying to say, okay, we could all learn this. This is not like rocket science. It's just deploying a loop. We wanted to go to Mars by 2030, and let's figure out how to teach others so that we can deploy a loop on a polyp. And what we are saying is that what's wrong in all of these things is the way we teach others, and that's what we want to correct. And when we just give didactic to our technicians, to our fellows, it's like Kobe Bryant didn't learn how to play basketball by sitting in a didactic lecture. And yet we teach our fellows all of these techniques by didactics. So let's try to follow up what Raju has tried to do. And I think he wants to show like, look, we can teach others. Let's go try using mastery learning. Maybe one day we'll talk about mastery learning and how to apply it for making all of our units anywhere to be much more adapt to doing all of these techniques.
Okay.
I have a quick comment.
Now, let's do one thing. He gave me a big talk, but he didn't tell us what he would do to remove this polyp.
No, before he goes there, I want to have a quick comment.
Yeah.
That is that I agree fully with what Dr. Satikno said. But only thing is that there is also a deficiency in the way the polyp, the snare itself. There is a need for improvement of the instrument. It is not just the inability of people to learn how to place it. I think part of it is due to the way the plastic loop just flips up when you are trying to apply. That is what makes it difficult. That is the only reason why I think teaching becomes a little more tricky. But otherwise, I fully agree with what he said.
Sriram, I think Raju will be sharing us that very technique to solve this loop, this poly loop to like flip up. So we will talk about that. Now, how would I cut this polyp? The one thing that could help, because this polyp is like occluding the lumen, would be to extend the cap. So the cap here is positioned at 2 millimeter from the tip of the endoscope. So when you have the 2 millimeter length cap, then it is really for the purpose of magnification rather than for therapeutic. So if you have the cap longer, which is like 4 or 5 millimeter, then you can have a few of what you wanted to do, or you can also put the accessory within the cap. So that could be helpful, because you will need to put the tip of the endoscope at that level where the head is. And you need to have visualization there rather than you need to have the mucosa coming at you. So that would be one thing that you could be doing. And I wonder if making the polyp floating could be helpful, but I'm not so sure about that. Other than that, I'll follow what Niam and Suber had been saying.
Okay, that's good. I really appreciate that. I'm going to share some of the thought process, all right? I think one is technique, but you need to have a game plan. You know, unless you have a game plan, you cannot really do the resection safely, even if you know how to use an instrument. So when you look at this polyp, you have a large polyp, you have a thick stalk, and you have a head almost occluding the lumen, right? And so then you look at basically two things. One is you look at the polyp and you look at the scope, right? Whatever scope you're using. And when you look at the polyp, you think about the head and you think about the stalk. And when it comes to head, can you make that head smaller so that you can either put a loop or a snare and then cut it? I think one of the things you have to keep in mind is when you don't have space and you are trying to put a loop, the loop could be entrapped in the head. And it happened in my practice where I thought that I got it around the head, but the loop got entrapped in the head. And then I had to come out, take a scissors and cut the loop. And I'm sure Roy and others may have faced a similar problem. So when you have too big of a head, it is difficult to put a loop or a snare around that head to come onto the stalk. So one option is, can you make that head smaller? And that is possible with epinephrine injection, using the concept of epinephrine volume reduction. So whereby you inject into the head of the polyp and then into the stalk of the polyp and allow the polyp to shrink. All right, that's one concept. The second concept is, say for example, you have the stalk and you know that you cannot really get around that head of the polyp, say for example, and you will have the skill sets of using a knife or a scissors type of electrosurgery instrument, then you can actually cut that with those instruments. So you don't have to worry about going around, putting the loop around, coming down, and then cutting the stalk. Instead, attack the stalk directly with instruments that you can use, like an SB knife or electrosurgery knife, one of those electrosurgery knives. The other option is the scope, right? You need to have the scope go around that polyp head. Typically, the scope is an adult scope or a pediatric scope, and you could put a snare through an EGD scope or even a slim endoscope so that you can wiggle yourself around that head to put that snare, something to keep in mind. And Roy mentioned this point of having a cap at the end of the scope, which is also very important, and that will help you to go around the polyp and have the cap disperse the polyp away from the mucosa, and so that you can have a beautiful view, and then try to do that. And when you're putting a cap for therapy, especially in narrow areas, and you want to have the cap serve like a retractor, you want to pull the cap out. It is about at least 4 millimeters out. And in that case, you want to tape the cap to the end of the scope. Otherwise, the cap might fall off, and then you're dealing with another issue. So, and it's also a good idea, like Roy suggested, to use water to allow the polyp to float and consider resection. So we talked about different concepts, right? Polyp head, can you make it smaller? If you cannot make it smaller, can you actually cut the stalk with one of the electrosurgery scissors, or think about changing the scope to a slimmer scope, adding a cap, adding water. So these are all different techniques that you can employ to cut the polyp. So I wanted to summarize them. And now, how do you cut the polyp? You can use a hot snare resection if you could put the snare around and come down. You can use underwater. You can use a long cap assisted. You could use a loop followed by snare if you can go around that, or epi followed by snare. Clip application to the base of the stalk followed by snare, or clip application to the base of the stalk followed by a knife cut. There are so many different ways. So, or you could use a knife cut followed by mechanical hemostasis. So,
Dr. Roger?
yeah.
I had a quick question. You know, like your approach where if we couldn't get over the stalk and even underwater or just changing position, but you go directly to the stalk. If in that technique, would you inject epi first?
Yes.
Because I know that I think that the placing the clip, I saw attending once place a clip before, and I thought that wouldn't be the safest, given that the electric surgery current would go through if touching the clip.
Right.
So how would you approach this one?
I think I'm going to share with you how would I approach in just 1 second.
Okay.
Okay. I think those are all important points to keep in mind. And the reason why I wanted to share different approaches is it's good to keep in mind, so that one could use, if one thing doesn't work, maybe you can go to another thing. All right. All right.
Mm-hmm.
Okay. Let me, so this is what we did. We went ahead and injected epi into the head and into the stalk, right? 1 second. And so you inject about maybe 1 to 2 cc's into the head of the polyp, and then you inject into the base of the polyp. Then the question comes is, okay, you've done the injection, you got a nice blanching there. When do you cut the polyp? Would you cut it immediately because the epi is still acting and you want to get a good hemostasis? Or you go up and come down and then do the resection. Let's do the next poll, Selvi, poll 6. Okay, so when do you cut the polyp? So do you cut it immediately, or you wait and go up, come back, and then cut it? All right. And people are about half and half, maybe 65% said they want to come back. So that's actually the principle of epinephrine volume reduction. You don't want to cut immediately. Instead, you go up, go to the cecum, and then come back. So we went to the cecum. And then we came back. You can see that, right? The polyp has become much better. and you can easily go around that polyp. So this is a concept that I think most people can use. You know, it is something within every endoscopy unit available. So you inject into the head, inject into the stomach, go up to the cecum, come back. It probably works in about 50% of the cases, you know. And after reading this paper that came out from Jackson, Mississippi, published in GIE a few years ago, I've been using this technique. It probably works in about 50% of the cases, and it works, it's great. So as you can see, you have a lot of space around that head of the polyp, and you could go and cut. So we decided to cut like Sriram talked about, right? You know, we decided to put a snare around. You want to use a stiff snare, and you want to make sure that you don't snare the head. You want to come to the base of the stalk and then use coagulation current and then cut. The other thing is when you have a thick, big head, you want to make sure that there's no one point of contact to prevent a counterburn. All right. So, but when you cut it here, you can have this thick vascular pedicle that you're seeing. And we decided to apply clips. And when you apply a clip, it's a good idea to apply a clip across the vessels so as to occlude them rather than on top of the vessel, as you can see here.
Raju?
Yeah.
So I was looking at where you put the snare. Maybe you could share your thoughts at that time so that everyone can follow the thinking that occurred during that microseconds of where should you want to put the snare.
Right.
How do you balance the need to cut at the neck and then the need to treat the bleeding that might occur and things like that.
Right. I think, Roy, thank you for bringing that up. I think the most important thing is the first step. When you look at the head of the polyp, and I'm sorry that I didn't include a lot of details of the examination of the head of the polyp. When I looked at the polyp, it was fluffy, like a vellus adenoma. And there was no bleeding when you did the water jet. There's nothing like an indurated area. And my clinical impression was I was dealing with a large benign polyp. I did not suspect any cancer there. So the next step was cutting the polyp, right? Once you decide it's a benign polyp, you want to cut the stalk. And if you think it is cancer, you want to cut the stalk as close to the wall as possible with a lot of distance from the head so that if you have a clear margin by more than 1 millimeter, even if there is a cancer, moderately differentiated, you would get a curative resection. So in this case, I thought it was a benign polyp, but I was still worried about bleeding. And one should keep in mind this. As we mature into endoscopists, our ability to deal with the complications changes. In the early phase, we want to not get into a big bleed and then go through the anxiety. So this was several years back, this was the case. So I thought that, okay, I was worried about bleeding. So I still had quite a bit of stock there that I left to cut. I left and cut above. And I felt that I was not dealing with a malignant polyp, so we should be okay. If you think it is a malignant polyp, you should cut a little bit below, giving yourself enough distance from the cancer. You want to comment on that, Roy? It's a good idea to comment.
I think what the fellows might want to see is that he actually left a little bit of the stalk so that, number one, he doesn't want to cut as close to the wall given of the possibility of thermal burn and the risk of coagulating the wall, the musculus propria. And there's a little bit of stock left, so that when cases happen like this, when there is like a herald bleeding occurring, then he has somewhere to put the clip onto it. So the clip can easily be attached and prevent the bleeding. So be very careful when you say, well, I need to cut as deep to the wall, because then there may be much more hard. It may be more harder for you to do what he just did.
So one point that I want to share with the trainees is when you cut, sometimes big vessels could retract into the wall that you may not be able to secure with any form of hemostatic devices. So something to keep in mind, that the vessels could retract into the wall and they may not be accessible. And I have seen a case that was presented at the ASC postgraduate course where a similar problem happened, and that patient required surgery for control of bleeding, which is very unusual nowadays, given the advances in endoscopic hemostatic devices, to have a patient go for surgery to control bleeding. On the other hand, if you look at Dr. Jerry Wei's teachings early on during their career in 70s and 80s, bleeding used to be a big problem because they were all afraid of perforations, and they used more like a guillotine cut. And he actually shares a very interesting story that when they were doing snare resection in the early 70s, the surgeon used to come, the endoscopist used to put a loop around the polyp and wait for the surgeon to come and cut. And if the patient bled, the patient was taken to the surgery by the surgeon. So from that point, we have come a long way. All right. So some of us has talked about it. We thought that whether we leave it alone with clips or should we do something else. And in this case, we decided to put a loop also because clips can actually loosen, right, with time. And if the clip loosens and the clot is not stable, they can bleed. So, and there is a randomized control study that showed that combination of mechanical hemostatic methods is better. So we decided to apply the loop, and I want to go through the principles again. You have a loop device and you have two parts. One is the sheet that encloses the loop. So if you move the sheet forwards, it encloses the loop. And that's what you do first before you put this loop into the instrument channel. And once your loop is in the field, you pull the sheet back and the loop comes out. And then you put it around the polyp. And once that happens, then you focus on the slider. And the slider is used to deploy the loop. So here is a video I want to show you. This was done by Laura helped me produce this last week. This is a loop device. And this was actually developed in the late 80s by a physician from Japan. His name is Tadashi Hachishu from Chiba area in Japan. And initially the loops used to be like a reloadable devices. So as you can see, the sheet is being pulled forwards to enclose. And then when it comes out into the field, you pull back. And then once it is around the stock, you go to the slider and then close the slider. And as you can see, there's a small plastic sheet at the end that actually keeps the loop tight. And then you reopen the slider to let the release the loop. Right. So those are the simple principles. They're not much. One is the sheet and the second one is the slider. So
I want to make a quick comment on that last part. Is it okay? So just a tip to save the instruments when you are trying to use it outside and trying to practice. If you can show me that last part of that video, if you see that plastic that slides towards the pen, actually once you deploy it that way, you can actually, okay, yeah, go forward, and now stop there. So now if you take out the loop out of the pen, you can actually hold the tip of the loop with one hand on the left and hold this piece of plastic and slide it back again. Now you have the loop again so that you can deploy it any number of times and play with it without using too many instruments.
yeah, actually, Sriram, I'm glad that you made that comment. That's what we did to shoot this twice. So the video was shot twice. First time we couldn't, we shot it, but there was so much of disturbance in the background. So we wanted to do a close shot. So we reopened and then did what you did. So
in fact, even in a real life situation also, suppose
this is the one that
something
you can
messed
pull
up.
back and then do that.
Yeah, even if it is not around the polyp, and if sometimes these polyps, these polyloops slip in the lumen, that is, it can still be reconstructed.
Thank you for that comment. So this is what we did. We felt that, sometimes you have to think about where the patient is coming from. And this patient actually came from at least 6 hours away. And we wanted to make sure that we have a secure hemostasis before we let the patient go. And because of that, we decided to apply the loop. And sometimes when you have a very short stock, you could use the clips as a pseudo stock. And you can take the benefit of the applying clips to make a pseudo stock and then close below the clips and apply the loop. As you can see here, that's what we did. All right. So for the sake of trainees, as you can see, loop versus no loop in terms of preventing bleeding. And again, loop plus clip better than just with just epi injection in terms of the benefits. So combination therapy, right. And one thing is I should have done here that I didn't do is as soon as the polyp is cut and there was no bleeding, I should have gone up and brought the polyp distal to the resection and left it there and took care of the resection site and then take the polyp out. So as you can see here, we put the loop, we have the clips, and the polyp was higher up, proximal to that, and we got it in the net and brought it up. And the reason I say that is once, quite some time ago, when I was taking the polyp back, the net actually got entangled in one of the clips with one of the clips hinges. And that would be a mess because you will loosen your clip as you're trying to remove the polyp. So since then, I started the practice of once I cut the polyp, if there's no active bleeding, the resection site looks okay. I try to get the polyp and suck to the tip of the scope, come down, deposit distal to the resection, go back to the resection site, complete the job. And then when you're removing it, you don't have to worry about any issues. So then we talk about, basically we talked about this in terms of the cancer. If there is cancer, this was a benign polyp. If it is moderately differentiated cancer with a 1 millimeter margin from the lower edge of the cancer to the resection site, And if there is no lymphatic or vascular invasion, you have saved that patient from surgery. So why don't I stop here, and I would like the panelists to talk, and we can answer some questions.
Hi, Raju, Ravi here. I have a couple of questions.
Yeah.
Especially when you demonstrated about injecting adrenaline to the head of the polyp and the stalk. Before you put in the snare, at what point do you feel comfortable? Like how much shrinking makes you feel that this is ideal for me to put the snare and cut it? Otherwise, the worry is as soon as you snare it, when it starts bleeding, the whole field of view is going to be bloody, and it's going to be a bit difficult.
Right. So what, Ravi, what I'm hearing is once you inject epi and see the polyp has reduced in size, when will you be comfortable to cut it? And then the question is you're concerned about bleeding and how to manage that. Is that right?
Yes. So I just want to know at what point you're comfortable. How much shrinkage is it like 50% shrinking or 75% shrinking? How much should the stalk reduce before you're comfortable putting the snare?
So one thing is what happens is when you inject into the head and into the stalk, and then you go to the cecum and come back. If that polyp were to reduce, it will reduce at least, the cases that I've seen are anywhere between 50 to 75%. All right. And what I'm concerned, what I'm looking for with volume reduction is not necessarily whether whether there's going to be bleeding when I cut the stalk. My purpose of volume reduction is that I could put the snare around the head of the polyp nicely and be able to go to wherever I want to go to the stalk, and then use electrosurgery to cut. Before this technique was available, I had patients where I basically bailed out and said, you need to go for surgery. Or I had problems with loops getting stuck in the head of the polyp or the snare getting stuck in the head of the polyp. And if a snare gets stuck in the head of the polyp, my suggestion is to try to reopen and get out and then reapply. Don't get into the habit of trying to cut that polyp head. Because the bleeding that happens in the polyp head is very difficult to, you cannot find out that bleeding spot to do hemostasis in the middle of the head. When it comes to the stalk, once you have a nice thick stalk, the principle of avoiding bleeding is basically how you close the snare and how much of Carter effect you're seeing below the snare and the speed of the closure of the snare so that you get good hemostasis. Another important principle that I have applied after actually getting burnt out, I think we discussed one of the cases before, is I always ask myself, is the resection site non-dependent or not? And if it is not dependent or not. If it is dependent and if it bleeds, you will not find the bleeding source. And it will bleed so fast that you may not find the bleeding source. It will pull out the blood. But if
Raju, let's go ask Niem and Suber. Is the cut stalk, is it on the dependent side or non-dependent side?
I think they don't.
I think it was on dependent side.
Dependent side. Niem?
Say the question again.
So you cut this thing, the stalk, the remnant, is it on the dependent side or non-dependent side?
In this patient?
Yes.
I'll say dependent side.
Dependent side. So there is no polyp standing up ever, because the stalk of the head would by gravity will be on the bottom, right? So when you see a polyp hanging, and when you see a polyp like standing up like this, and that means that the polyp is hanging. So that means that the stalk is going to be in the non-dependent side. It's on the roof. That's the only reason why it could be hanging. So if it was bleeding, it would be poured out to the other side.
One other.
I don't know. Will Raju agree or not on that?
Yeah, no, you're right. One other simpler principle to apply is to always put some water and see where the water is in relation to the stalk. If the stalk is submerged under water, and then if the patient bleeds, you will not see the bleeding area. If the stalk is not submerged in the water, then you know that if it bleeds, the blood will come to where the water was. You can find the bleeding coming down and you can secure the bleeding. So one thing is, when you are cutting the polyp, unless you cut too fast and there's no coagulation of the blood vessels, usually when you cut slow and let it coagulate, the chances of bleeding are less. And the second thing is, whenever you're doing resections of polyps like this, you have to be prepared with the clips available there on the back table. And you know that you're going to apply a clip irrespective of there is bleeding or not. So I tell my assistant, open the clip, get it ready before I put my foot on the pedal to cut the polyp, because I do not want to waste any time to control the bleeding. The second one is, if the bleeding happens and you have a stalk, you have the snare there, don't pull the snare out. Reopen the snare, go around the stalk, close around the stalk and sit there for 5 minutes. You'll have excellent mechanical hemostasis, and then reopen and do whatever needs to be done. So one thing is, when you use an electrosurgery instrument, once you finish the job, don't pull out the instrument, stay in the field so that you don't have to waste any more time to do the next step if you want to use the same instrument for hemostasis. So
Raju?
Yeah.
Can we take a couple of questions in the chat box?
Yeah.
So Joseph was asking if you would share your thought process in terms of the ERBI settings, if you were cutting that large pedunculated polyp without putting an endo loop on or putting clips on the base previous to cutting.
So if I'm in the past, I used to do pure coagulation. That was before I became familiar with ERBI. And once I became familiar with ERBI, I've been using FX3, Endocut Q, FX3, duration 1, and I push the interval to 6 or something like that. But more important is that you take the ownership of the snare closure into your hands. And once I close the snare tight, I'm not in a rush to cut immediately. I basically close it tight, wait for several seconds for some form of mechanical tamponer to affect, slow down the blood flow or whatever, and then try to cut with Endocut Q316. And having said that, it also, in between, I've also applied coagulation current. But a polyp like this now, if I see this, I would use Endocut Q316 and cut it slow, watching what happens below the snare closure. You want to make sure that there is some whitening happening there so that you know that you're having coagulation. And the speed of your snare closure is a technique that you have to practice by watching the stalk and the appearance of the stalk as a current is going through. and you're reflecting on that. And I recommend that everybody record their video so that you can actually see what happened, because it's very hard for us to remember what we did. And the only way you get better at it is by recording your video and rewatching what happened to your case. If the case went well, and then you can reflect on that, that's good. The other thing is the problem when you record, you don't know when you applied your current because there's nothing that shows up on the screen. So when I was trying to figure out how to teach people how long did it take for the cut to happen, I started, taking a photo at the beginning of the cut, or changing the white light to NBI, like a marker on the screen, and then cut. And that way, at least I know that this is what's happening.
That's great, Raju. We also have a question from your friend Emil, and he was asking about how about a knot tire to control the stock base?
I think it's an interesting concept. It's like the surgeons doing a knot tying. We don't have an instrument. I believe I think some of the Japanese investigators are looking at needle thread similar to surgeons using and trying to apply some closure. But of all those things, the simplest is still the loop. If you use the loop, you can manage probably 95, 98, 99% of pedunculated polyps.
There's one more question, Raju, in the chat if we have time.
Mm-hmm.
So Sammy was asking, we were talking about different techniques in order to measure the thickness of the stock, ruler, visual inspection, et cetera. And he was suggesting using the water jet, which was a novel concept to me, to evaluate the size of the stock, because the size of the water jet is 1.2 millimeters, he says. What do you think about that?
I think the most important thing is you need to have a reference measure, like the pathologists use, like the radiologists use, like a reference scale, that you have it on the same screen and use that to measure whatever lesion you want to measure, and whatever you think works. But at the same time, the water jet depends upon where you keep the water jet, how, as the water comes out, it spans out, right? I'm not sure how accurate it is going to be. Simpler thing is, when you have a lesion that you need to cut, you have to take out an instrument and use the same instrument in the same field of the polyp. Take a picture. It takes, when you take a polyp image, another picture is polyp image with an instrument by the side. That would be the simplest to do. All right.
Thanks, Raju.
So I just want to conclude, basically, for the sake of fellows, when you see a polyp, you want to ask yourself a few questions so that the patient doesn't care. All that the patient cares is whether you cut it safely and you cut it completely. They don't care how you cut it. So there are a few things you want to ask yourself. Is it a pedunculated polyp? Then look at the head. Is there cancer? Look at the stock. If it is too thick, you should be prepared for managing bleeding. That's a bigger problem with pedunculated polyps than perforation. Then check at the relationship between the lumen and the head of the polyp. You have to be prepared and avoid getting into trouble with the loop or the snare and getting stuck in the head of the polyp. And when you cut, and you think about having the ancillary techniques available so that you could cut safely. All right, thank you so much. Thank you, Niyam. Thank you, Zubair, Sriram, Selvi, Sylvia, Roy, Ravi, Dr. Graham, everybody, thank you so much. Hope you have a nice Sunday. Be safe. Take care.
Thank you.
Thanks, everyone.
Thank you all.